Well, thank you for giving me the time. I'm going to transition gears and talk about systolic heart failure management in 2021 and beyond. So in my opinion, it's a really exciting time to be in the field of heart failure. We have several relatively novel medical therapies as well as device therapies. And I'm going to try to get through at a very, very high level some new things that we're doing today at Wellstar in our program. So we'll talk about medical therapy, which is really the hallmark for systolic heart failure. Most of these patients can feel well on medical therapy. We'll talk about a novel device that we're now implanting. We'll talk about stage D heart failure. So once someone transitions to stage D, they're going to be refractory to traditional medical therapy, and you need to do more to get them feeling well and preserve survival. And then a few additional therapies that we won't get into in any detail, but I want to mention them because they're available and they're out there. So this first slide is a algorithm derived from the 2021 update to the 2017 expert consensus document on treating stage C systolic heart failure. And I'm going to spend a few minutes here because really this is the bread and butter for stage C heart failure. We talk about GDMT goal-directed medical therapy, but not everybody really knows exactly what that means. And this slide basically tells you what that means. So first and foremost, anyone with stage C heart failure, which is evidence of structural or functional abnormality of the heart, in particular, we're talking about reduced DF heart failure here, and symptoms related to that structural abnormality should be on an ACE inhibitor, an ARB, but actually more importantly, an ARNI, angiotensin II receptor blocker / neprilysin inhibitor. And this ARNI or Entresto, which is a fixed dose combination of sacubitril valsartan, is really the hallmark of treating systolic heart failure in patients that have acceptable renal function and acceptable blood pressure. It was FDA approved in the 2015 timeframe based on the hallmark trial Paradigm Heart Failure, which came out in the New England Journal 2014 publication. It was studied against enalapril 10 BID and proven superior in terms of survival, reduction in rehospitalization, and symptom improvement. And that's what we're seeing in real life with this medication. Patients really do feel better. I do think they live longer compared to ACE inhibitors and ARBs. And they are not in the hospital. Patients on Entresto do well. And then over the next couple of years, they released 2 more trials. So Paradigm was an outpatient trial. The drug was initiated in the outpatient setting and titrated up over the series of a couple visits over several weeks. Pioneer Heart Failure in 2019 was an inpatient trial. Entresto was proven to be safe and effective when initiated in the inpatient setting. And then Prove Heart Failure is a study that actually documented the reverse remodeling that we see with Entresto. So we are seeing EFs get better than they get on ACE inhibitors and ARBs alone. And we're seeing these left ventricular end diastolic volumes and diameters get smaller. So the heart's getting smaller and stronger on Entresto. So first and foremost, ARNI or sacubitril valsartan or Entresto, whatever term you want to use, these patients should be on this medication if they've ever had a symptom and they have reduced EF heart failure. Hospitalization initiation is fully appropriate. And then beta blocker. Most of us are aware that these patients need beta blockers, but some of us forget that there's really only 3 that have been FDA approved for prolonged survival and reduced rehospitalization in the reduced DF heart failure population. So carvedilol, which we use a lot of here in the Wellstar system, but also metoprolol succinate, not tartrate, but succinate, or Toprol XL, the long-acting version. And then the third is bisoprolol. And most people don't use bisoprolol in this country. It's not. It's much more popular in Europe. But as a heart failure specialist, I do use it in certain occasions when the patient's appropriate. So everyone should be on Entresto, and if they can't tolerate Entresto, ACE or ARB, plus these specific beta blockers. So those are 2, but there are actually 4 medications now that folks would be on. So we're not done with just 2 meds. We're now really thinking about 4 meds. The third medication is going to be a mineralocorticoid antagonist, which would either be spironolactone or eplerenone. Both of these medications they're kind of considered interchangeable. Eplerenone is a little bit more specific to the mineralocorticoid receptor and has less gynecomastia. So you can get that one if the patient's on spironolactone first and develops gynecomastia, but either one is thought to be efficacious. And so that's medication number 3. And then number 4 is new, and I suspect many of the folks on the line may not know that we are now regularly and actively using the SGLT2 inhibitors in class 2 through class 4 reduced EF heart failure. And so dapagliflozin, which is Farxiga, and empagliflozin, which is Jardiance, are both regularly accepted medications to use in the reduced EF heart failure space for stage C patients. And so dapagliflozin was FDA approved a little over a year ago now, but this trial is from 2019, the first major trial of an SGLT2 inhibitor in reduced EF heart failure, the DAPA-HF trial. And so it was New England Journal in 2019, 4,700 patients, EF less than 40%, class 2 through 4 heart failure, GFR greater than 30, but in reality, most patients had a GFR of greater than 45. And so this trial showed an improvement in survival, reduction in rehospitalization, and an improvement in quality of life. And the benefit was seen in patients with and without heart failure. For those familiar with this class of drugs, they were initially FDA approved for diabetes. The SGLT2 inhibitor is predominantly in the kidney. Sodium stands, or the S stands for sodium, the GL stands for glucose. So they inhibit the reabsorption of both sodium and glucose in the kidney, and by doing so, improve heart failure symptoms. And so again, this was FDA approved almost a year ago, May 5th, 2020. And so we're using this regularly now. And then the second publication, major publication for specifically in heart failure with this class, was the empagliflozin trial called the Emperor Reduced trial was the name of the trial. Similar design to the DAPA heart failure trial, but in fact, sicker patients, so lower EFs and lower GFRs, GFR down to 30, but more patients in that GFR 30 to 45 range, which we commonly see in our heart failure patients. This trial also met the primary endpoint, which is a reduction in heart failure hospitalizations combined with cardiovascular death, but really it was driven, the endpoint was driven by the reduction in heart failure hospitalizations. And I think the really remarkable thing that was shown in this trial, and there's a suggestion of this in the DAPA heart failure trial too, is that there's a suggestion of renal preservation, in that these, pretty much all heart failure patients over time will get a decline in GFR from the volume overload, volume shifts, and the medications that were used, and chronic inadequate perfusions in the patients that have very low EFs. These medications we think are actually going to delay the reduction in renal dysfunction, which is a very strong thing in our field. So this is not yet FDA approved, but we are using it regularly now. With this trial and the expert consensus document, we're now able to get prior authorization and get it approved in patients, even if they don't have diabetes. And so I wanted to show this study. This was a cross-trial analysis estimating the lifetime benefits of comprehensive disease-modifying pharmacologic therapies in patients with heart failure and reduced EF. And it looked at, as a baseline, people that were just on ACE or ARB and beta blocker, and then showed the improvement in survival that they would get if you add a mineralocorticoid antagonist, if then switched to ARNI and added a SGLT2 inhibitor. And so this is a little bit of a confusing slide, but if you look at the graph on the top left, with conventional therapy, a 55-year-old gets an additional 6 years of life with heart failure by being on ACE or ARB and a traditional beta blocker. But if you add mineralocorticoid antagonist and SGLT2 inhibitor and switch to an ARNI, you're actually increasing from 6 to 14 years of additional life. And so by looking at this analysis, they suggest that a 55-year-old likely confers an additional benefit of 8 years of event-free survivals, which is really remarkable. So when we're trying to get patients on these meds, and a lot of them are actually feeling well outside the hospital, they're NYHA class 2, and we're telling them, well, you need more meds and switching meds. And this is compelling evidence as to why we want to do this. Patients on these meds, these 4 meds, they almost invariably do well. They just do really, really well. They're not in the hospital, they're at home enjoying life. And so this is really the target. Now we're really talking about 4 meds in these patients. And so I use this football metaphor to drive the point home. The sacubitril valsartan combination is your helmet if you're a football player. The beta blocker is your shoulder pads. The mineralocorticoid antagonist is your cleats. And then the SGLT2 inhibitor now is your thigh pads. And so my favorite football player is Barry Sanders. And here's Barry Sanders with helmet, shoulder pad, cleats, and thigh pads, warding off tacklers as if I like my patients to ward off heart failure, hospitalizations, and death. And so when I use this metaphor, people, even the women in this part of the country, everyone loves football for the most part. They get this and they get on board with taking all these meds. And I wish there were a super pill that had all these meds in one, but unfortunately there isn't, at least not yet. And transitioning to devices. So most folks are aware of cardiac resynchronization therapy or biventricular ICDs, and you can see the chest X-ray here. There's a right atrial lead, a right ventricular lead, and an LV lead that's cannulated through the coronary sinus and out at the lateral wall. And by biventricular pacing these patients, particularly patients with a very wide QRS, often they feel better and live longer. We have the strongest evidence in this setting for a left bundle branch block morphology with a QRS of greater than 150. That's the only class 1 recommendation. And then we also have less strong, but still pretty good evidence for any QRS that's greater than 120. These are class 2 recommendations. But what about narrow complex patients that are still struggling? These patients that are not candidates for CRT, they're on the right meds and they're still struggling. Is there any device therapy that can help them? And so now the answer is yes. It turns out that about 55 to 60%, this chart says 59%, it's in the 55 to 60% range of patients with stage C heart failure have a narrow QRS. So these narrow QRS patients are not candidates for CRT. Of course, they're candidates for a single chamber or dual chamber ICD, but not CRT. And then a single chamber or dual chamber ICD is really not going to make a patient feel better unless they have some component of, the heart block, which most of these patients don't. And so this device, this Barostim Neo device, which I'll talk about in a minute, can actually make patients feel better. So what is the Barostim Neo device? Well, it's an FDA-approved device that actually regulates the autonomic dysfunction that occurs in chronic heart failure patients. So chronic heart failure patients have increased sympathetic output. That's why we give them a beta blocker. They have this increased neuroendocrine activation because of poor renal blood flow and poor cerebral blood flow. So your sympathetic tone is up and your parasympathetic tone is down. And the Barostim Neo device is a device that's implanted in the right chest, and the lead is actually tunneled not to the heart, but up to the carotid sinus, usually the right carotid sinus, and sends a signal to the carotid sinus. And by doing so, it inhibits the sympathetic activity and enhances the parasympathetic activity. And the outcome of that physiologically is a decrease in heart rate, a decrease in cardiac remodeling, increased vasodilatation, increased diuresis, and a reduction in renin output. All those things, of course, are good for heart failure. So over time, what we saw in the clinical trial and what I've been seeing in clinical practice is that these patients are actually feeling better. And this was published last summer in the Journal of American College of Cardiology, 2020, Baroflex activation therapy in patients with reduced EF. And so the BEAT heart failure trials, 264 patients, all with an EF of less than 35%, and all on optimal medical therapy, but still NYHA class 3. And they all had narrow complex QRSs, so no indication for CRT. And at 6-month follow-up, there was an increase in exercise capacity as defined by 6-minute walk, an improvement in quality of life as defined by the Minnesota Living with Heart Failure score, and a statistically significant reduction in NT-proBNP. So with all this positive data, it led to their FDA approval. Now, we haven't seen, as of yet, reduction in rehospitalization or survival benefit, but again, this trial was only 6-month data. They should be publishing 2-year data within the next 6 to 12 months. And I'm optimistic that we might actually see survival and reduction in rehospitalization once we have a longer outcome. So we were involved in the clinical trial. We have our longest patient with this device is about 3 years out. He's doing remarkably well. And in 2020, we started doing commercial implants, and those patients are doing well also. So I'm optimistic that this device can help us in these narrow QRS patients. And we were the only center in Georgia to be involved in the clinical trial. And we were the first center in Georgia to do a implant outside of the clinical trial. And so this device is FDA approved for symptom improvement for class 3 patients or patients who are class 2 but had a recent history of class 3, low EF, NT pro BNP less than 1600. These patients are more likely to benefit, and it's not indicated in patients with CRT. And so if you look on the left, this is a real chest X-ray of one of our real patients with this device. On the right of the screen, you'll see his single chamber ICD. Most patients, and that's of course his left chest. So most patients have these implanted on the left just by convention. And on the left of the screen, which is the right of the patient, you see the barostem neo device, and you see a lead tunneled upwards to his right carotid sinus. And then transitioning from stage C to stage D, if you take a look at this slide, most patients actually feel relatively well while they're in stage C. They might be in the hospital here and there, and they lose their functionality to an extent. They come into the hospital, they get diuresed, we get them back on meds, and hopefully get them on the meds that I just mentioned, those 4 classes, and their functionality improves to a level that is acceptable to them, and they go on about their life. But at some point, these stage C patients are going to transition to stage D, such that we can't really get them feeling well outside the hospital. We can't get them back on their medication because the blood pressure is too low, or these medications make them feel too poorly. And once someone is stage D, their 1-year mortality approaches 90%. And so one of the ways we can identify these patients, this also comes from the expert consensus document, is looking at these high-risk features. So anyone who's ever been on IV inotropes, anyone who's persistently severe symptoms outside the hospital, people with worsening renal dysfunction, people with severely reduced EF, folks who are now getting shocked by their ICD, folks who are in and out of the hospital, persistent edema despite escalating diuretics, anyone with low blood pressure or a high heart rate, that's a high-risk feature. And then once you start down trading the goal-directed medical therapy, that's a high-risk feature. So someone who used to tolerate high-dose Entresto at 97/103, now their blood pressure is 90/50 on low-dose Entresto. He's still on Entresto, but he's not the same patient he was a couple years ago when he was on high-dose Entresto. All those things are high-risk features. And so once someone gets to stage D, really that's when they need to see someone like me who's trained in advanced heart failure cardiology, because these patients need more than what traditional therapy can provide. And so really there are only 3 therapeutic options for stage D heart failure. The first is chronic inotropic support. So we do have patients that are out of the hospital doing well on milrinone and dobutamine. Sometimes this is palliative, i.e. they're going to live the rest of their life on dobutamine or milrinone, and they'll at some point get worse, and then they'll transition to a true hospice if they're not already hospice. But for patients who are younger and have more life left ahead of them with less comorbidities, we can try to get them to a definitive therapy, i.e. left ventricular assist device or cardiac transplantation. And the latter two, LVAD and transplant, have been clearly proven to improve survival in the stage D population, whereas the inotropic support patients, they make patients feel better, but they don't necessarily improve survival. And so Wellstar now has a left ventricular assist device program. We implanted our first LVAD about 4 years ago, and the last 2 years we've done about 20 a year, but we've started off well in 2021. So I hope to get to 25, 30 implants this year. And for those who are not terribly familiar with what an LVAD is or does, here you see a cartoon representation with the pump itself implanted in the LV apex. Here, this pump is connected to an outflow graft, which anastomose to the ascending aorta here. And the pump actually will take blood from the left ventricle, pump into the ascending aorta, and from there it's disseminated to the rest of the body. The major Achilles heel, as I see it, with these pumps is the fact that the power source is not fully internalized. So you see here, this patient is carrying batteries on his shoulder, or kind of over a shoulder harness underneath the kind of flank region. Those batteries are actually outside the body. So the pump, of course, is inside the body, but the batteries are outside the body, and you need a way to connect the batteries to the pump. So the batteries are actually connected to a system controller, which is here, and then the system controller is connected to a pump via this cable here called a drive line. And a part of that drive line is outside the body, but the rest of it is inside the body. So the drive line is what is the connection between the VAD and the system controller. And there is a exit site through the skin, which we call the DELS, or drive line exit site. And of course, puts the patient at risk of infection. So and patients have to carry around these batteries, they have to carry around the controller. So that's the major Achilles heel of this therapy as it stands in 2021. As I see it, both manufacturers, there are two manufacturers of VADs in this country, and both are working on fully implantable systems, but we're not there quite yet. And so in terms of survival with LVAD, you take a patient who probably has this 1 year survival of 10 to 15%, and you change that to a 1 year survival of 80 to 85% with an LVAD. So it's a remarkable change in treatment course. We, I sometimes say we resurrect these patients. Most of them are, almost fully dead by the time they get to the OR, and 6 months later they're back to work and back to life. It's really remarkable. One of the pictures that Dr. Menino showed earlier of the axillary balloon pump was actually a VAD patient of ours who went from axillary balloon to LVAD, and now he's back at work. He's not quite a year out from his implant, but he's back at work operating forklifts. And here's an example of an LVAD patient. This is a patient that lives in Cobb County. She gives me permission to show this slide at my talks. Lovely lady, believe it or not, she's in her 60s. She looks like she's younger than I am, but she's a 60-year-old lady with history of 3B breast cancer diagnosed in 2014, and then a corresponding adriamycin-induced cardiomyopathy diagnosed in 2015. And as of summer 2018, she was stage D, inotrope dependent, but we were unable to get her listed for transplant due to the proximity of our cancer diagnosis and the unclear risk of recurrence. They thought the risk of recurrence at 3.5, 4 years was just too high based on her 3B cancer prognosis, cancer status. And so she just got sicker and sicker. We were trying to get her to transplant, and ultimately there was nothing left to do but get her to LVAD. And so she was implanted with an LVAD in October of 2018 as a bridge to candidacy. She recovered from her LVAD. They got more comfortable around her cancer being far enough away and the ability to treat it even if it recurred. So we got her transplant listed and then ultimately transplanted about 14 months later. So this was our first of many LVADs that went on to transplant. And so just in wrapping up here, things we didn't talk about: CardioMEMS, which is an implantable pulmonary artery sensor. And it just so happens that the folks that make one of our LVADs also make CardioMEMS. So in the future, we will have LVADs that are able to adjust speed based on a PA diastolic that's low or high. So communication between a pulmonary artery sensor and an LVAD, and real-time changes in speed based on what's going on physiologically. So that's one of the next things that will happen in the future. There's a device called the Optimizer RX that will compete with the Barostim Neo, which actually delivers a small, low energy current during the refractory period of the QRS. And by doing that, increases intracardiac calcium. And by doing that, increases EF and makes people feel better in the clinical trials. There's a newer drug that just got FDA approved a few weeks ago called vericiguat. It's an oral soluble guanylate cyclase inhibitor, which increases cyclic GMP and increases nitric oxide circulation. So it's a vasodilator. This drug has an improvement in rehospitalization risk, but doesn't actually prolong survival. Mitral valve intervention, e.g. MitraClip, is something we talk about in our heart failure patients that are appropriate. And again, I mentioned this fully implantable left ventricular assist system with fully internalized batteries and a feedback loop. So this is the future of heart failure. We're at 4 meds, then devices, then transplant VAD, but here we are with 5 additional things that are on the pipe for the next few years. So the future for us is bright as I see it. Thank you all. That's all I have. And I think I'm the last presenter. So if we have any questions, I'd be happy to answer them.
Hey, Brian, this is Sal. Tremendous talk. And I applaud of what you have done for our institution. I mean, you have taken us to a much different level. And thanks for your dedication and passion. With regards to, and it's a two-part question. So with regards to patients who have new onset systolic dysfunction, I still see people using ACE inhibitors to start and then say we'll consider other stuff down the road. Given the superiority of data, is there really any role to start an ACE inhibitor, or should we either start Entresto and an ARB or an ARNI at first? And number two, I mean, the data with life expectancy is quite compelling. We have patients, or I have patients that we think have done well for years that have been on ACE inhibitors. Should we be switching those patients to an ARNI?
So first, thanks, Al. First question, my opinion and the opinion of anyone who does this all day, every day, is everybody should be on Entresto if they can tolerate it. The main reasons folks can't tolerate Entresto is going to be marginal blood pressure and renal dysfunction. So in the trial, about 20% of the patients fell out of the clinical trial. So what they did is they randomized patients to 10 BID of enalapril. If you could tolerate that, then you got switched to Entresto up to 49.51 to the middle dose. And if you could tolerate that, then you got randomized. So 20% of the people fell out of the trial because they couldn't tolerate enalapril 10 BID, or they couldn't tolerate 49.51 of Entresto. And that's about what I see in real life. Some people just can't tolerate it. Their renal function goes bad, or their blood pressure goes too low. It makes them feel too bad, et cetera, et cetera. But I give it to everyone. My colleagues do locally and across the country. And I start them on it from the very beginning, and then I switch them to it if they come to me. If I get a patient that's doing well, quote unquote well, but on an ACE or an ARB, everybody gets switched to Entresto because it does make many people feel better. And if they don't tolerate it, they don't tolerate it. But in my opinion, you are doing a disservice to patients by not putting them on Entresto.
Ryan, this is Harvey. Thanks for that excellent talk. A number of our patients actually normalize their left ventricular function and yet remain on 5 or 6 medications. Can you comment on whether or not these medications should be continued indefinitely, or whether there could be some weaning of these medications, or what are your thoughts on that?
Good question, Harvey. So there's a study that came out a couple years ago from Europe called the TRED heart failure, TRED-HF. And they took, the sample size wasn't very large, but I think it's about 50 patients, actually probably about 100 patients that all got new onset heart failure, and they all recovered. About 50, they kept them on the meds, and about 50, they stopped the meds to see what happened, which I don't think you could do that here, but it was done in Europe. So they stopped the meds because the standard is actually to keep patients on these meds. And in the 50, so it's only 50 patients, but in the arm where they stopped the meds, in 6 months, 80% of people's EFs dropped again. And that's what we see in real life. When we stop these meds, these EFs go down. I have a story of a patient who had been EF of 10% at time of diagnosis, 10 to 15%. He recovered to 45%, chronically NYHA class 1 to 2. And he did well for about a decade. And he missed the follow-up, and he's like, well, my heart's better. I feel good. I probably don't need these meds. He stopped the meds. And then 7 months later, he's in our ER and in shock. And 4 or 5 weeks later, we can't get him off of 2 inotropes, not 1, but 2, milrinone and dobutamine. So we can't even get him out of the ICU. And he ends up leaving the hospital with an LVAD. I mean, that's what happens to these patients. When the EF goes back down, they sometimes goes back hard. And all heart failure experts have stories about like this, the one that I just shared. So I keep the patients on all the meds. Now, what I tell them is there's a risk that I share stories. There's a risk if there's virtually no risk if we keep you on the meds. There's just a significant risk if we stop them. In terms of can you stop any of them, the SGLT2 inhibitors are so new. They're so new. So is it probably okay to stop the SGLT2 inhibitor if someone's on one and their EF recovers? Probably. And then the other one that I think about stopping as well is the mineralocorticoid antagonist. But I would never stop the ACE, ARB, or AR9, nor the beta blocker. I think the evidence of keeping those drugs on board is just too strong.
Ryan, this is Jeff. Just to follow up on that. So for myocarditis, for example, where you expect that 30% of them are going to recover, you typically take meds off at that point. Would you agree in that situation or disagree? I
think there's risk, man. I think there's risk only because I see the worst of it. So my perception is skewed with these catastrophic circumstances of patients where meds were stopped and bad things happened. Now, if you very clearly have a viral myocarditis with hard objective evidence of a viral myocarditis, and everything fully recovers and the evidence of the myocarditis is gone, I don't think it would be unreasonable to stop. But a lot of times these patients will come to me with a presumption of a viral myocarditis, but no one's done a cardiac MRI, no one's done a genetic screen, so they haven't really been fully worked up, because a lot of these viral myocarditis patients actually have a hereditary cardiomyopathy that's never been diagnosed. They have a Titin mutation or a phospholamban mutation or one of these mutations. And if you have that and you stop the meds, it could be a disaster. So I think if you have, in your situation, you're probably seeing the pure, true, not hereditary, not familial, no genetic component. Someone got a virus, they have an MRI, and sure, they have myocarditis. In that situation, I don't think it would be unreasonable, particularly in a young patient. But there's probably some risk there. I think you'd also have to make sure they don't have anything hereditary.
Thank you.
Yeah.
Hi, Brian. It's Nydia. I have a question. What about the patients that have pregnancy-induced cardiomyopathy?
Yeah.
What is your thought about it, especially when they're young and they want to get pregnant again? And we all know that they shouldn't, but what about the medication regimen? And then, go ahead.
No, so I'll answer that one first. So a lot of these postpartum cardiomyopathies, so I check all these patients for mutations because many of them have mutations, and the most common one we see is a Titin TTN mutation. So think about all the patients that get pregnant, right? Most people don't get pregnant and have an EF of 15 to 20% after their pregnancy. So oftentimes there's something else. It's the stress of the pregnancy is the second hit, but the first hit is something hereditary. So all of them I check. Anytime I'm seeing a postpartum cardiomyopathy, I'll do a genetic screen. And I would say probably a third of them come up positive. And so in those patients, I absolutely wouldn't stop. And if they want to get pregnant, if they have EF recovery and they want to get pregnant again, I don't recommend it. I don't. I mean, I don't, again, because I've seen the catastrophic circumstances. And, I have a couple patients that I've seen over the years that have wanted to get pregnant again, and they wanted me to say, yes, it's okay. And I just don't say that. And I've sent them to get second opinions, and the second opinions will always say, no, it's not okay. You shouldn't. There's major risk to you, and there's major risk to your unborn child. Not to say that they can't get through it. I mean, we have had patients that have gotten a second pregnancy after their first, they had a peripartum, they got better, they had a second pregnancy, and they can get through it, but there's just a lot of risk. I mean, it's a lot of risk there, Nydia.
Yeah, no, I agree with you. It's just sometimes, by the time you have told them not to do it, and they've been on the medication, they get off the medication, they get pregnant, and you have to deal with that, which is the worst part of it.
Yeah, absolutely.
My second question was, and I apologize if you touch about this, but I had an emergency phone call that I needed to take. With the new Vercuvo, where do you see the role of that medication in the heart failure patients? Good
question. So I don't see it, because there's no survival benefit. I don't see it replacing the four that I talked about. So I don't see it replacing Entresto, beta blockers, MRA, or SGLT2 inhibitors. The main benefit and they actually didn't even show a quality of life. The main benefit that they proved that led to their FDA approval was reduction in rehospitalizations, which is similar to Coilinor or ivabradine. Ivabradine really didn't show a survival benefit. It did show a reduction in rehospitalizations. So I see it kind of like a ivabradine in that, okay, if you can't have a patient on all four, and it's someone who is at risk for hospitalization, or they've been frequently hospitalized, then it's something to think about to reduce their future risk of rehospitalization. It's kidney neutral, which is a good thing. A lot of these meds with the renal dysfunction that these heart failure patients have, they're tough to get on board or tough to titrate. So I think it's a good thing that it's kidney neutral. In the trials, it really didn't drop blood pressure, which is also a good thing. One of the downsides, though, is unlike the SGLT2 inhibitors, which you just start everybody at 10 and that's it, you don't have to titrate the dose, or aldactone, you know, most people just start at 25 or 12.5 if the renal dysfunction is severe enough, and you're not titrating up the dose. With vericiguat, you do have to titrate. So you start at 2.5, then you go to 5, then you go to 10, which is, of course, you know, it just requires follow-up, and it's a little bit of a pain in the butt sometimes to get, you know, now have a third med that you got to titrate. So I see it as an alternative as opposed to everybody should be on 5. I don't think we're going to be saying everybody should be on 5 meds in a year from now.
Thank you. Great talk.
Thank you.
Dr. Howard, sorry.
No, I'm sorry, go ahead.
This is Joanne. Dr. Howard, I wanted to ask a fairly basic question. With the patients with marginal blood pressure already on ACE and ARB with the beta blocker, and if we have to choose between RA and RNA, switching to RNA, which one should we actually try first? Choice
between which ones, Joanne?
Adding MRA to ACE or ARB and beta blocker versus continue beta blocker and switching ACE, ARB to RNA.
Gotcha. So it's number one, it's pretty well established in the heart failure community that it is better to be on low doses of 3 or 4 meds than like max dose of Coreg, but not on an ACE or ARB because the blood pressure is too low. So low doses of all the meds we think are better, just because they all work differently. And each mechanism of action we think is additive in terms of survival benefit, reduction in rehospitalization, et cetera, et cetera. So low doses in general, but try to get is better and with getting everyone on all the meds. And then in terms of kind of switching, which is better, I mean, like I said, I'm a big Entresto fan, not because I work for whoever makes it. I can't even remember. I don't even know. But because it really does work. So I try to get everybody on Entresto if they can tolerate it. And one of the tricks, not even a trick, but if you think about pharmacologically how Coreg works versus Toprol or bisoprolol, Toprol and bisoprolol are beta-1 specific. So they're beta-1 antagonists. Coreg is an alpha beta, so it's non-specific beta and alpha-1 blockade. And with that alpha-1 blockade, I do think you get more of a blood pressure reduction effect with Coreg, particularly in someone who's already on Entresto, which of course also has vasodilatory properties. The sacubitril from Entresto for sure vasodilates. And so one of the things that I often do if someone is, you know, I'm trying to get them on meds and they're just not really tolerating stuff, and they're on Coreg and I'm trying to get them on Entresto, I'll switch to Toprol. Not because there's any data that Toprol is better than Coreg, but because Toprol does not block the alpha-1 pathway, and oftentimes you're going to have more blood pressure room. And I found, for whatever reason, I found that particularly in diabetics. So diabetics that have maybe some undiagnosed neuropathy and not good vascular tone because of the poorly controlled diabetes for years, a lot of those folks do better on Toprol and Entresto than carvedilol and Entresto.
Very helpful. Thank you.
You're welcome. Dr. Parikh, I see your comments. I will send you the football slide.
Oh, thank you.
Yeah, I mean, it's a lot. It's a lot of meds. So of course, these patients don't just have heart failure. They have heart failure and diabetes and coronary disease and all kinds of stuff. So just 4 meds with one disease state is a real challenge. It's a challenge to get people on these meds, but you know, it's the right thing. It's the right thing.